Hello, everyone, and welcome to the Research Roundtable. We are ending 2025 on such a high note, and we are so immensely honored to have with us Dr. Corrado Campisi. Dr. Campisi is a member of the European Society of Lymphology and the president of the International Society of Lymphology. An alumnus of the University of Genoa, he attended surgery of lymphatic pathologies and microsurgery and received 2 masters in reconstructive microsurgery in healthcare and pharmaceutical administration. A surgeon, researcher, professor, and expert in the best use of lymphoscintigraphy diagnostics for the study of lymphatic insufficiency of the upper limbs. Today, our focus is on how pneumatic compression added to decongestive therapy improves outcomes before lymphatic surgery. And so we've got so much to discuss. Of course, you know, Dr. Karen Herbst. Wonderful to see you, Dr. Herbst.
Nice to see you.
We'll be leading the conversation. And we know that the hour is a little different than normal because Dr. Campisi is gracious enough to join us from Italy. Now, we would have loved to have joined him in Italy, as Dr. Herbst did back at the World Congress. But for now, we will settle for Zoom. If you have questions for Dr. Campisi, please do put them in the Q&A, and we will weave them in throughout the conversation. But this is the best part. I disappear and let 2 brilliant people have an amazing conversation. So with that, Dr. Herbst, take it away.
Thank you so much, Brenda. And Dr. Campisi, welcome. It's really an honor to have you here on the Research Roundtable. And I'm sorry I missed you at the Lipedema World Congress. I wish we could have said hello, but there were, 800 people there.
Yes, thank you, Karen. For me, it's a great pleasure to be here with you in this fantastic research roundtable because I've seen many of your topics also in the past. It's very interesting. Bring up all the new updates in our field that concern lymphedema, lipedema, and all these diseases to offer the best solution for the patient. It was a fantastic opportunity to share our experience in Rome a few weeks ago.
Yes.
I saw you, I heard like your talk, but then we're moving from one room to another one. It was a very busy meeting, and
Yes.
but I'm happy to be here with you now and happy to see you.
Great. So just to start out, I wonder if you can give us an idea of how accepted it is or how common it is to treat lymphedema or even just, swelling before surgical procedures, not just microsurgery, but also like, for example, knee surgery.
Yes, this is a very important statement because I have been working a lot on this issue because my experience, the way I started to evaluate the importance of this kind of decongestive treatments in patients that were planned for a surgery, for example, a microsurgery or a liposuction for diseases like lymphedema or lipedema. But you are very true because a lot of these tools can be used in many other kind of surgeries. You mentioned like a knee surgery, but I would say that it is very important before surgery to prepare the patient, but also after surgery. So that's why we've been developing other studies of post-op. We have 3 studies. I will explain about this that are just started, just ongoing, and also studies about some therapies can be effective for a faster recovery also if the patient use some protocols also at home. So there are many options, but for sure everything that can cause a swelling of course can be prevented. So before surgery can be a preparation, can be also a prevention.
And so it sounds like you are very involved in pre-hab and rehab, but do you think other people in your field are doing the same thing as you're doing?
I think is not really a vast majority. I think usually people think no about. I think they don't think out of their box, like to say. No? So, for example, I'm a plastic surgeon. I need to do a liposuction also for an aesthetic reason, not necessary for a pathology. And I do the liposuction, but I don't. Maybe I see the patient a few days before. I see the patient for a short follow-up, maybe after 1 month. But I'm not really in a system in which many other professional healthcare figures are like helping to prevent, for example, a swelling after liposuction, or to treat as well as swelling after. So I think we should push this forward. I know that there are many doctors that are really concerned about the fact that the patient may develop some complications like swelling after some kind of surgeries. But you can imagine, for example, an orthopedic surgery, but imagine a surgery can involve upper limbs, lower limbs, surgery in the abdomen as well. But also think about, for example, spine surgery as well, no? When the patients need a lot of rehab after. So technically, everything that can cause a swelling, like a trauma, it can be also surgical trauma, like a iatrogenic trauma, should be evaluated and prevented. At the same time, we know that there are, a lot of literature in the medical world is raising about the importance of specific protocols that can be delivered after a specific kind of surgery to help the patient to have a faster recovery. One of the studies that we just started evaluates all the use of specific devices such as IPC in particular, so intermittent pneumatic compression in patients after aesthetic liposuction. So how you can improve the recovery of patients after an aesthetic liposuction, for example?
Mm-hmm. I think that adding on a piece of equipment like an IPC is going to be more important if we are going to pre-hab and rehab people before a variety of different surgeries, like you mentioned, including spine surgery or anything iatrogenic that's done to the body. And I think it makes perfect sense to have a piece of equipment that can do that. Otherwise, we need people. We need more and more and more people treating before and after, and that gets expensive. And I think it makes perfect sense. And so on that note, could you please tell us about your research study that you did with the Lympha Press Lympha Pants added to decongestive therapy before your surgery?
Yes, the study that we performed a few years ago was a study that was then published in the journal Lymphology, and the study was focused on the pre-op preparation treatment of patients that were undergoing surgery for lymphedema of the lower limbs, so the legs. And this study compared the standard decongestive treatment regimen and with the use, so what is ongoing now. No? Technically, you do manual lymphatic drainage, bandaging, skincare, this stuff. Compared with the use of the IPC device. IPC under specific protocols that were delivered to patients before surgery, so preparation to surgery. And this study on a good amount of patients showed that there was a very significant statistical improvement, better improvement with the patients that were using IPC compared to the patients that were only doing a standard decongestive therapy regimen. That's why...
Can you just tell us what your standard was? What's your standard regimen?
The standard regimen means manual lymphatic drainage plus bandaging,
Okay.
skincare, this stuff, but without the use of any other machines. Okay,
Perfect.
so no machines, no devices. So technically, a certified therapist performing specific kind of manual lymphatic drainage of the lower limbs and eventual bandaging together with skincare or all the other tools that we have available without using any device. And this was compared with the IPC device in the pre-op period, so in preparation, so the decongestion of a lymphadematous arm, sorry, a lymphadematous leg in preparation to lymphatic surgery, lymphatic microsurgery.
Great. And what did you find?
We found there was a huge difference because the difference was higher than 7-8%. So it was like a very good, very good difference. If you imagine that the amount of patients that we studied was not like huge. No, we were speaking about two groups, 25, 21 patients that were treated, and so that's why we started to collect more data. And so the data we then decided to collect were the data that about what happens after surgery. So after surgery, the patient, goes have an optimal decongestion, then goes through surgery, and then maybe has an immediate post-op care for sure. And then we start to think, okay, how can we help the patient to have, let's say, more freedom after a specific procedure or a surgical, let's say, protocol, possibly improving the long-term standing results that you can achieve after surgery. That's why we thought about this home study that we are publishing soon because we finished to collect all the data. It's a little bit more difficult when you collect data from home because the patient has to be very compliant, because you give the protocol and the patient has to do a specific thing. And so you have to reach out to the patient, speak with them, collect data, measure. And I think that also the way you measure is extremely relevant because sometimes, when you measure some circumference randomly, so you can also have some results that are not working. So also the way you measure is very important. We used very specific parameter optoelectronic measures to evaluate this. And so this study will come out soon because we are submitting it now, and we are also developing other free studies. I told you one about the faster recovery after liposuction in patients that use standard post-op regimen that usually is a stocking after liposuction, stocking or contention, let's say. Compared to the use of intermittent pneumatic compression. This is one. The other one is, again, comparing the standard decongestive treatment with the use of IPC in patients with breast cancer-related lymphedema, so upper limb related to breast cancer. And the third is doing the same with a very specific type of patients. These are the patients that are affected by a phlebolymphodema. So a lymphedema that also have a venous component. And as you know, also when you do the congestive therapy in these patients, you have to be very careful because when you try to treat the lymphatic insufficiency, at the same time, you can make the venous circulation worse. So it's a very delicate balance between the lymphatic system and the venous system. So this is also the other study we will perform. So these three studies are ongoing, just started simultaneously, and we will collect all this data. There is a good amount of patients that will be enrolled in these studies, and we expect to have the end of data collection by the beginning of next summer. So let's say late May, beginning of June, and then analyze the data because we strongly think that these devices are extremely useful to doctors, surgeons, therapists to access the best possible outcomes if you use them pre-surgical, if you use them post-surgical, or if you prescribe these to patients for home use as well.
So a couple questions. How soon would you start therapy with a pump after microsurgery, for example?
This is a very interesting question. Honestly, the protocol I follow up is, the correct answer is where is the site of microsurgery? Because if microsurgery was performed, for example, let's think about the leg. Depends where is the site of the reconstructive microsurgery, because and also how deep is the lymphatic reconstruction, because it's very superficial. Pumping too much can have some complications in the immediate post-op phase. But also, if the microsurgery, so for example, the lymphatic anastomosis is a little bit deeper, but you risk to create some lymphoria, so some water, accumulation in the area where you did the anastomosis. So this was also a question I was asked in Antalya. There was the World Congress of Lymphology in October. Which are your protocols after microsurgery? Usually, I start let's say the treatments, the congestive treatment post-op after microsurgery at least 1 to 2 weeks after the surgery. But for example, if we have a bilateral lymphedema, for example, I say to the patient, okay, for the first 7-10 days, we don't touch the leg that received microsurgery. We perform the treatment in the contralateral leg, for example. And after 7 to 10 days, we check the patient. Usually in the first 7-10 days, we check the patient every 2-3 days. And if everything is healed perfectly, we restart the therapy. If the concept is different, if we do a liposuction, for example, if you do a liposuction, my suggestion is as soon as possible, is immediately to restart.
Okay, because I was sharing your data from the liposuction study, and it looks here like you start right away, and you start your measurements on day 2.
Yeah.
It looks like day 2.
Yeah.
Okay.
So the measurements are taken. It depends if the patient does a full intensive decongestive treatment period all together. So let's say concentrating all the therapies every day. But the most important thing is to take the first measure, then to take the measure before the surgery. Then usually I say we do day 2 because the patient stays in the clinic usually 2 days. Okay, so for surgery like that, usually the patient stays with a compression, with a bandage, at least for 2 days, and then you check the leg, the arm, the place where it is performed the surgery, and then you start with measuring. Yes.
Great. So I have another question, but I want to, based on what you just said about that you might treat one leg that didn't have the microsurgery on it for a while. There's a question from Lympho GWG Canada, and they want to know, would you use a different kind of pump in your clinic, especially if you're only going to pump one leg? Are there any other pumps that you use besides the Lympha Press?
No, honestly, these studies were performed using Lympha Press. Of course, there can be other pumps that can be used because in my clinic, I have also a lot of devices that were designed and patented by us for our use. But the difficult thing is to standardize. Even if when you speak about physical exercise. and you tell a patient to lift the arms, so you cannot control the ROM, so the range of movement every time. So if you want to propose a protocol, something that can be standardized and to be reproducible easily, you need to be able to measure what you do and to repeat it in the same way, at least, no?
Right,
So
true.
Lympha Press and this device, IPC device, helps you to standardize the thing. Because unless, you know, what I do in my clinic can be different than another doctor or surgeon does in his clinic, no? So
Right.
standardize means the same machine, the same pressure, or the same range of pressure, if you like exercise, range of movement. So standardizing helps you to repeat the same things and to reduce the margin of error. Yeah.
That makes perfect sense. So a
But
question.
regarding this question, I would like maybe to add one thing.
Sure.
If the patient, for example, with lymph press, use a pantalon, and after surgery, we don't want to push on the leg that had just received the surgery, we
Right.
use another tool. So we put like a monolateral sleeve, and we
Right.
leave, we don't touch it, so we don't put the pantalon again, but we
Right.
maybe the monolateral sleeve, and then the leg that received the surgery is not touched until we decide it can be touched, and again go back to a pantalon, for example.
That makes perfect sense. So you use like a single leg sleeve when you need it, and then you use the Lympha pants if you can,
Yeah,
because it's a more comprehensive treatment.
I prefer that, yes.
So the question from Cindy Robertson, she wanted to know if the patients in your study did use the Lympha Press in the clinic or if they actually used the pump at home.
In the study that we published in lymphology, they used in the clinic.
Okay. And that
And
was just to ensure that they
yeah.
actually used it.
This means the complete decongestive therapy delivered to the patient in a specialized center before surgery.
Yeah, okay.
In the study that we are publishing soon, we are speaking about the post-op home care by patients. So these are
Perfect.
devices given to patients to use them at home. Yes.
Great. That's perfect. So the other part of this question, I think I can answer from Cindy. She says if a patient is using the Lympha Press at home, how is this covered by insurance if they don't meet all of the typical requirements? And I will say it's really important to work with your healthcare providers, but especially a occupational therapist, a physical therapist, a licensed massage therapist who has education in the lymphatic system in order to get the correct forms completed in the correct manner for you to get a pump. Because I'm not sure what how you don't meet typical requirements. Okay.
Yeah.
That
I
takes care of
agree.
that.
I mean, I know that the audience is from United States,
Yes.
but it works the same also in Italy. It works the same also in Switzerland, because I have two clinics, one in Italy and Switzerland. You need specific requirements. But of course, if you have, if you work for your insurance provider, but also with the help of the physician that is following you, you can find the best tailored solution for you. Because, for example, in Switzerland, insurances are covering these treatments, but you need specific requirements. So you need, for example, the certified physiotherapists need to take measures, prove the insurance how is your that you are improving, and then that you need like some home treatment that will lower the cost of other treatments that can be delivered in another way. So technically, we are saying the patient is more free to enjoy his life, and we prescribe something to keep this long-term outcome that the patient can use in specific moments during his daily life. This is an objective to give the patients more freedom after an intensive care of treatment.
Perfect. So I'm going to ask this. I hope I'm not answering it at the same time, but you compared multi-layer bandaging, which is a static treatment, to bandaging plus an IPC, which is active treatment.
That's
Why
right.
do you think that, how does this pump give that 7 to 8% reduction in volume? Why does it work?
As far as I know, and I've seen also with my experience in the last years, it adds much more to the static treatment. Okay, as you said,
Mhm.
because as far as we know, if you perform a very good bandage, and if the bandage is very good, then you know that after a few hours, the effect of your bandage, if it's a well-performed bandage, we lower and lower and lower. Okay,
Mhm.
so what happens this gives more strength to the treatment, and we know that synergic treatment, so multi-treatments work better than one. But the fact is that, and I go back to what I said before, these things have to be standardized because even bandaging, there are many techniques and bandaging has to be standardized. So that's why this has to be performed by a certified therapist with knowledge on all these treatments. And in this way, adding the plus of IPC can improve. And if you think on big volumes, a 7-8% of difference is a big difference in big volumes.
Yeah, well, it's a huge difference. Yeah. And I think I'm just going to add this and see how you feel about it. But one of the unique aspects of the lympha pants is that the chambers are overlapping. So that when you push fluid with one chamber, then the next chamber inflates, it can't go backwards. It has to go up the leg. And I think, looking at other pumps,
Yeah.
that the Lympha Press really
Yeah.
has come up with such an amazing design for their chambers that prevents backflow. Would you
Yeah.
agree?
Yeah, absolutely. And also, even with a good therapist that performs good manual lymphatic drainage, it's difficult with two hands to avoid this phenomenon of a little bit of reflux when you do the treatment, because you go forward, but when you go further, you only have two hands. Okay,
Right.
so to avoid these overlapping chambers, they work like a very good bandaging. Okay, so you overlap and you push with different sequential pressures that allow the fluid to go out from the place, from the limb that you're treating, for example. And the good thing about the pantaloon, that's why I like the pantaloon, it's technically, I prefer the pantaloon when we speak about from the feet to the belly at least, is that
Yes.
it does not only treat until the groin, for example, but it helps you
Right.
it stimulates all the collateral pathways, lymphatic pathways that are in your lateral, anterior lateral aspect of the thigh, the gluteal region, the lower abdominal region, in which there are essential lymphatic pathways that drains the lower limbs and also the genitals as well. Okay, so in this way you really work in a comprehensive way also in the lower part of the abdomen as well, and you can work in the anterior part, in the lateral part, middle part, and as well in the posterior part. So it's very comprehensive treatment.
Wow, I have so many questions. You're just stimulating my brain so much here. So you mentioned that there are lymphatic pathways in the lower abdomen that are important for the drainage of the upper thighs. Is that correct? So why do so many people feel that there is such a distinction between the leg and the abdomen? And I think the people that know lymphedema well know that edema can spread from the leg up into the pelvic area, the groin, the abdomen. But the people in the lipedema field feel that the abdomen is completely separate from the legs. Could you explain that?
This I can tell you for sure. This comes from anatomy, and you know, also many years ago I did many studies also on cadaver dissection with together with the University of Buenos Aires.
Mm-hmm.
We studied all because these studies were mainly performed for cancer. Okay, so we
Mm-hmm.
did for the axilla and we did for the groin. So we were trying to understand why the same typology of patients that undergo some surgery on the axilla or on the groin, why some develop lymphedema and why some do not, even after radiotherapy in some cases. So
Mm-hmm.
I said, okay, there should be something that is for sure related to the number of nodes that were eventually removed, okay? But there are for sure anatomical issues, okay? And we know that upper limbs, lower limbs, they have collateral pathways. These collateral pathways, they go in the chest or they go in the abdomen, okay? So this means
Mm-hmm.
that are pathways that do not go through the main lymphatic bundles that are the axillary one in the upper limb and the groin. And
Okay.
so just these bundles can go, for example, for the upper limb in the anterior part of the chest, in the posterior part of the chest. The same is also for the lower legs. So, and if you study anatomy, you know that the lymphatic system, for example, coming from the feet, collects, no, goes from the feet to the popliteal nodes. Popliteal nodes are deep nodes, and from deep nodes, they receive both superficial and deep lymphatic flow, and then they send with other collectors, deep or superficial, the lymph to the inguinal lymph nodes. Inguinal lymph nodes can be superficial, the vast majority is superficial, but also deep inguinal nodes. And these nodes then go through the inguinal crease and go up to the abdomen. And this happens very deeply. So where for example, when they perform a lymphadenectomy for cervical cancer, for prostate cancer, they touch those nodes. But if you imagine that some woman with maybe they were treated with cancer, they never developed cancer, for example, with a lymphadenectomy in the pelvic region, never
Mm-hmm.
had any swelling, then they need an abdominoplasty with a very
Yeah.
superficial scar, and after an abdominoplasty with a very low scar, they develop a lymphatic problem. This happens also in women that deliver a pregnancy with a funny incision, so with a cut, no, without not a normal delivery with the cut. There are many pathways. Another proof to this is that as a plastic reconstructive surgeon, many flaps can be free flaps or can be propeller flaps. You can turn 180 degrees. These flaps are based, I mean, lymphatic flaps on superficial lymph nodes that are over the inguinal ones, that are in the hypogastric and lower abdominal region. And this drains the superficial lymphatic network that's coming from the legs, for example. So that's why we cannot think the abdomen completely different word from the legs. Because this comes from anatomy, this can be explained by treatments in which, for example, cancer treatment is involved. And this has to be considered because the collateral pathways are the one that when there is a huge lymphatic impairment, we should think about, evaluate, study. We can study them. There is lymphoscintigrate, there is ICG, there is a specific kind of probes with the ultrasound in which you can study the lymphatic pathways. So why they are useful? They're useful because if we tell a therapist that there is a collateral lymphatic pathway, the therapist will work on that and she will have a fantastic improvement. So this is basically based on anatomy. And what is nice about the IPC when it's delivered in a proper way is that this really stimulates also the collateral pathways. For example, in the upper part, in the chest, the jacket does this, okay? The jacket does this. If you put the jacket and you want to treat the arms, the shoulders, the upper chest, the back of the chest, the mammary region, the jacket can help you to do that as well.
Thank you so much. So is this why you prefer the Lympha pants? Because of that connection between the lymphatic system and the abdominal system?
Yeah, I do, and especially when you focus mostly only on legs, you may miss a part because a single sleeve also cannot treat the lateral part. When is the region of the tensor fascia lata region. So the upper part of the gluten region cannot be treated with that. So I mean. This is why I prefer it. Of course, if the patient is extremely thin, has a problem that is mostly distal, and the problem is only monolateral, you may choose also to use a single sleeve. But if you perform a treatment and you know the lymphatic network is all connected, especially in the lower limbs, even if the problem is on one side and you deliver the treatment in the normal limb, you still are improving the lymphatic drainage because there is also a huge amount of medical evidence that I know, because some people think, okay, this patient has a problem on one limb, so we do manual lymphatic drainage from the foot to the groin, for example, okay? But there are many, many studies that prove that sometimes it is very useful to perform manual lymphatic drainage on the left axilla for a right leg problem or a contralateral inguinal that helps to drain the affected limb. So there are many, many studies also that were done. We published one in lymphology about the very strange lymphatic pattern of diffusion for melanomas. So the unconventional lymphatic pathways. Sometimes a patient used to have, for example, a melanoma, so skin cancer of one hand, and let's say right hand, and the metastatic node was on the left inguinal region. Okay, how can you explain that? So from the right hand to the left groin. Okay, how it goes there, no? So that's why a comprehensive way, of course, every patient has a specific necessity, and all the tools, instrumental tools that we have available to study the patient can help us to make the proper decision. But I think the lymphatic system should be treated 360, not only localized in one side.
That makes sense. And I think we're going to be learning more over time about that. Can I circle back? One of the things you said in the beginning of the hour was that, and I believe you were mentioning how microsurgery can, or other surgery can lead to exacerbation of venous insufficiency.
Yeah.
Could you explain that a little further? Because a lot of us don't do that kind of surgery.
Yeah, I mean, especially with microsurgery, you know that there is a huge, I mean, you can be a fantastic surgeon. The patient can be a fantastic candidate for surgery, even not too much advanced. So let's say perfect condition for a successful surgery, okay? But if you don't study the venous system, you may do a fantastic job and put all these collectors in a vein that will not work, because when we do this surgery, the patient is not in the standing position. The patient is is laying in the bed, no? Okay.
Right.
So, which is the effect of the venous pressure on what we do, which is the pressure, the venous pressure against the lymphatic pressure. This is the same also when you do physical therapy, decongestive therapy. What happens, which is the risk of relapse, no? And if you do a microsurgery, which is the risk of clotting the anastomosis, if there is a contact between the blood and the lymph before the valve apparatus, okay? So that little segment from the lymphatic to the valve has to be only full of lymph, okay? In the laying position, but also in the standing position. So we all know that the venous pressure also in people that have very normal venous system or initial, very, let's say, aesthetic venous insufficiency, the first vessels that are affected are the very superficial ones. And then slowly, the deeper ones, so the greater veins. So what we want to know and want to be sure is that what we are using for the anastomosis will work also after. So the long-term patency is an issue, okay?
Right.
So we can evaluate it in the standing position, evaluating, checking for the veins, and having like a very high flow through the anastomosis. A good way, and many surgeons are doing this more and more. We have been doing since really years and years, but now I see many other reconstructive surgeons are doing this. They prefer to use more vessels in one vein with different feature anastomosis, terminal, terminolateral, to increase the lymphatic pressure against the vein pressure. So this is really essential. So technically, we open something that was not working. So after the surgery, the physiotherapist, the certified therapist, bandaging, IPC, all will work much better if you open really a channel that was not working. But the venous system is really one of the most important factors for the success of this surgery.
That makes sense. I didn't know that I guess I kind of knew you evaluated the vein that you were going to connect the lymphatic vessel to, but I didn't know you did it standing. And are these veins even? Yeah. Are these veins tributaries? Are they collectors? What kind of veins are they?
The veins that we use for the anastomosis are veins that are, let's say, 95% of the cases, veins that are bigger in caliber. For example, in the groin, I make an example. Usually, of course, if there is a saphenous vein, a great saphenous vein, we don't use the great saphenous vein. But we use many tributaries in the saphenous-venous junction. So which are the tributaries? The superficial circumflex femoral vein, the deep, the superficial inferior epigastric vein that arrives there, the accessory saphenous veins, the external superficial pudendal vein, or all the collectors of this or branches of these veins. The key point is that these veins, when you cut them, and of course you select them pre-op, and then you check during the surgery. You can change also the position of the bed to them, okay? But when you cut them, you don't need to put even a clamp, okay? So the vein has no reflux. So you wash the vein is clean, empty, and you know that the segment will be clear of lymph. If there is a very slight reflux, but not important, you can wash the vein more, check if the valve apparatus is like in the right position. Sometimes just need to flush the vein. But if you have any doubt, there are techniques that are technically owned by the vascular surgical ward, because I did my fantastic fellowship program at Mayo Clinic in vascular surgery when I was in the States with Professor Glovitsky. I was a student of him when I was 2008, so some years ago. Mayor in Rochester, Minnesota, and you can repair this valve apparatus also putting some few stitches, not necessarily 360 degrees. You can do 180 degrees to perform an external valvoplasty that allows the competence of the vein without injuring the vein wall. You can do it, check, flush, working, and then you do the anastomosis. So the lymphatics do not touch blood.
Got it. I think that the surgery is just amazing that you can actually do it and it works and you really are helping people. Do you have anything that I missed that you would like to focus on?
Yeah, what I loved because also I was very enthusiastic 2 years ago when I came to Potsdam in Germany, and you and Dr. Simarro spoke about the theory, no, that is
Yes.
around lipedema, and I
Still
was
writing it, but yes.
and I love it, and I love it.
Yes.
And I
Yes.
love it, and I'm really, it's like a thriller, I'm like a crime movie. I have still to understand who is the killer, No, it's like I'm very excited
You're a
about.
detective.
Yeah, I'm trying, you are
Yeah.
detective too. So, and
Yes.
what I was thinking is that it's really important because in this theory, you're speaking about a lot about the compartmental syndrome, no? That
Yes.
known
Yes.
this thing. And also speaking about this abnormal fat hyperplasia that comes also in the saphenous compartment, okay? And
Yes.
as you know very well, that in the saphenous compartment, in that layer, there is for example, for the legs, there is the highest concentration of lymphatic structures, so nodes and lymphatic vessels. So this is very important. This is what I want to say is like in my personal experience, I think that lipedema is a spectrum, is highly related to lymphatic issues. Okay, so that's why we say, and I believe that is useful. Lipedema patients, true lipedema patients need decongestive therapy, IPC, eventually bandage, all these things, because there is a huge lymphatic component, and mostly in the legs that can be related to patients that have that are overweight, but also in patients that are completely normal. They are not overweight, they do exercise, they eat well, they go to the gym every day, they do CrossFit, but they still cannot avoid this fat deposition with time. So this is what
Yes.
I wanted to tell you because I really love this
Thank
theory.
you. Thank
And
you.
I am a fan. I'm a fan.
Thank you. Do you think in this theory, it's interesting because if the fat is around the veins and the lymphatics in the compartment, it makes lipedema a vein and lymphatic disease. Would you agree?
Perfectly.
Yeah.
Totally.
And there's
Totally. And
go
think
ahead.
about these patients that have this huge amount of fat deposition, huge amount of inflammation that justify, the fact that there is a huge inflammatory deposition, especially T cells around vessels, nerves, inside the adipocytes, out in the space between the adipocytes, that justify the fact that at the beginning the patient thinks, oh, this is just some cellulitis, aesthetic thing, or these bruises on the skin, the pain when the patient just does some manual lymphatic drainage. Some patients are really suffering. Okay, so I think it's related, and when you see the evolution of this disease, even in patients that are not overweight, you see a huge involvement of the venous system as well. Yeah.
Yeah. Do you think that in people who have lymphedema, that there is also a component of compartment syndrome there as well?
I think so. I think so. That's why now it's not done so much, but in the past, when it was an issue, especially in the lower part, in the legs, especially below the knee, I would say, there was a technique. Was a technique promoted by plastic surgeons. They were doing like a fasciotomy
Yes.
Cutting, on the medial part and the lateral part at the beginning was like a huge scarring. It was not very nice to see. But the
Yes.
concept was to make a communication between the superficial and deep system cutting the fascia, because this huge amount of inflammation was really creating a compartment syndrome. Then
Yes.
after that, they tried to be, let's say, less invasive in performing this communication with a using of an endoscopic procedure with a small incision, putting a trocar, cut the fascia with a single incision, less invasive, but always the concept was the two systems has to be in communication, because there is a compartmental syndrome, okay? It's the same
Mm-hmm.
concept. You have, like, for example, an electric barn, no? The electric barns that are very dangerous. They are
Yes.
they have a huge risk of compartmental syndrome. Some people can lose the use of the limb because of this. And one of the first things, even if with an electric barn you don't see the barn, but to prevent it, you have to cut the fascia and to give this communication, because there is a compartmental syndrome that affects also the vascular structures that are there. So I think it's like a way I can maybe help you to understand my point of view. I completely think this is the right way to think of it.
Mm-hmm. Yeah, I do too. And we just need to still fleshing out the concept a little bit, linking it to like why does it start? If you had to think of a reason why compartment syndrome would start, what would be your theory?
Karen, I give you an idea. I was thinking this with a guy that is a very important gastroenterologist in Italy. He's a professor, and he's the director of. Maybe we can do something together, because he's the director of the specific clinical nutrition in a big hospital in Italy, and. We were speaking because I was telling him what should we suggest patients, because nutrition is such important, in
Mm,
these things.
huge.
We're speaking, brainstorming. We're having like we're chilling with a glass of wine. No, it was not really. We're just speaking, brainstorming together one evening, and he said to me, why don't we think that because this adipocytes and the huge inflammatory component is not reactive to diet, is not reactive to many things, to exercise, why don't you think there are specific markers in the wall of these adipocytes that creates this, let's say, compartmental syndrome? Because things
Mm-hmm.
they don't go out, okay? There is a
Mm-hmm.
huge hyperplasia. And of course,
Yes.
there is a huge hyperplasia in lipedema. What happens is then with time, there is a lymphatic involvement. The lymphatic involvement that happens after in the true lipedema allows this water so to go out from the cell and to accumulate in the interstitial space between the adipocytes. So I
Mm-hmm.
think we should look on the markers on the wall of the adipocyte that can explain why things go inside and they get stuck and they promote
Mm-hmm.
inflammation and hyperplasia.
Mm-hmm.
I think this. I don't know if you agree, but
Yeah, no, I do. And I don't know if you're looking at genetics for lymphedema for your patients, but I've been doing that for my patients, and I have an idea which I would be happy to share with you offline, and I could do that by email. But are you looking? I mean, obviously, we know in the future genetics are going to become part of clinical care. Are you looking at lymphatic genes in your patients at all?
yeah, we are for sure. And especially, I think there are genes related to channels. Uh,
Yes, I agree. I
Genes,
agree.
because genes related to channels. So we are
Yes.
looking for a specific pump and channels that, of
Mm-hmm.
course, they are a production of a gene synthesis. Okay, understand? But
Yes.
I'm looking from the end point of this gene let's say, product that for me it's a specific pump, a channel on the cells, and in this
Yep.
case, adipocyte cells that
Yes.
justify this. I
Yes.
think,
Maybe we're thinking of the same one.
yeah,
Yeah.
yeah.
Could
So,
be. Could
so we
be.
can speak about that because
Yeah.
few weeks ago I was having, let's say, a nice moment with this colleague. He's very good, very a good guy, researcher, and I was speaking as a surgeon
Hmm.
because I was sharing with him, all the results I have for this fat tissue that I take from liposuction. We analyze the fat tissue, and so we have many options to look for specific things in this fat tissue. Okay.
Yes. Yes.
So I was thinking, okay, it should be a channel that is really accumulating, stimulating this hyperplasia and inflammation, of course, related to a genetic problem, then with this endpoint. This is
Hmm.
a fantastic thing, but I think we are in the right. It's not easy. It's not easy, but
No, it's not.
yeah, yeah,
Yeah.
we can do something like together if you want. I mean, more.
Yeah.
I love this topic.
Yeah, I love this topic too. Uh, and you've seen, of course, Saverio Cinti's work on lipedema, where he showed that there's a lot of calcium deposition everywhere, and calcium deposition is associated with inflammation. But that also begs the question of whether calcium channels are important in that
Yeah,
disease. But I would love to. I think they have a lot of the lymphedema genes, but one of the things that I find very interesting in the lymphedema world, and I know we're coming to the end of this, is that um, the medications that they're using to treat lymphedema are usually anti-inflammatory. So what genes are important in the inflammatory component of lymphedema? And I'm sure there's, it's hard to read everything, but I'm sure there's papers on that. But I think that's also an area that's
yeah, it's a
important.
yeah, yes, for sure, and there are also many new things as a surgeon. I'm using a lot. I'm sure that you know about that. About I used one a few days ago in a patient from Venezuela for arm lymphedema after
Hmm.
lymphadenectomy for melanoma, but a male. So man of 50 years old, more or less, from Venezuela. And I'm using a lot of scaffolds to regenerate the lymphatic system.
Oh,
So
nice.
I'm trying to help, because also there is a lot of evidence, many studies done in the States, a lot of studies for primary prevention when you touch a node that are now ongoing in Stanford University. So, I mean, there are many things that can be done, but also the lymphatic, how can we enhance the lymphatic regeneration if there is a problem? This is another big question.
Yes. Yes. Agreed.
And Dr. Herbst, the audience hates when I show up again because that means we are coming to the end of what has been one of the most riveting, interesting hours that we've had on the Research Roundtable. I can't thank you both enough. I know, Dr. Herbst, you've got a full patient schedule today. Dr.
You do.
Campisi, people are traveling from all over the world to come to the Campisi Clinic. Thank you for making time. Our audience truly appreciates it too. I heard so many wonderful comments in the chat. And Dr. Campisi, I do know that you had slides. Was there anything on your slides that you wanted to share?
No, no, just what was said with Karen. So technically, it was all the things of the all the literature that is beyond what we're saying. Because me and Karen, we are not speaking because we only think something. We are speaking because our thoughts are based on science. And so
Mm.
this comes from science. And so when we want to confirm something, we want to go and look and check. We're very skeptical, skeptical.
Hmm.
But there are things that are very nowadays very clear. And I think that today was a fantastic opportunity to share our knowledge.
Thank you so
Awesome.
much. I am so happy that I got to be here. I was afraid I would have to leave, but I am so happy to miss one drop of what you had to say. And it's been an honor and a pleasure. And thank you so much.
I feel the same way. Thank you all. Have a wonderful day. And we thank you for devoting your work that's ultimately helping so many patients, both of you. You are an inspiration. Have a wonderful day, everyone. See
Thank
you.
Thank
you.
you.
Keep in touch.
Bye.